Well, thanks, Professor DuBois, for the very kind introductions. I think before I start, I should also again, like other speakers, thank the organizing committees for the kind invitation so that I can come to this nice city and meet some old friends in Ho Chi Minh City, and also to give my views on this titles. The title that I was given is From the Embryo Implantation to the Clinical Pregnancy Rates, What Challenges? But of course, it's understandable that the immediate challenge that I need to face is probably, I think, I need to keep you awake after the very nice lunch. Well, I think in vitro fertilization treatment is quite effective treatment for different causes of infertilities, especially if we look at the information before the IVF sort of implementation, then we would certainly say that actually is a very major sort of achievement in our medical treatment. However, only about 20 to 30% of embryos will implant. Well, certainly, if we now move on to the blastocysts, then a much higher percentage of these blastocysts will probably implant. But if we use the early cleavage embryo, then that is the scenario. And of course, the implantation is a very complicated sort of process which involves the interaction between the embryos and also the endometrium in a very timely manner. And a lot of molecular pathways are involved. And whenever we are talking about infertility treatment, then patients will have a very high expectation of getting pregnant. Of course, some patients will probably get pregnant after 1 or 2 attempts, but unfortunately, in a certain proportion of the patient will not be able to do so despite repeated sort of attempt. And we actually, in our clinic, will be actually seeing this sort of patients on a regular basis. And some of this we call repeated implantation failure. And of course, like many other sort of scenarios in our reproductive medicine, we always face the problems, what actually the definition of the repeated implantation failure? And it does seem that every people are using their own definition, just like Paul have mentioned in his lectures, the same scenario like the poor ovarian response. So these are actually just sort of some consensus from some questionnaire, or actually some authors will actually use the criteria when they actually plan a study. Well, this certainly is not an exclusive one, as if you probably read the more recent one, then they may actually use a sort of lower cutoff. So this actually is quite a sort of, this is a Tang study in 2005. Sorry, let's see the, sorry. So 2005, so quite some years ago, these are questionnaires in UK. So then they actually defined repeated implantation failure as 3 fresh IVF cycle. And of course, you can see here immediate problem or limitation is it doesn't take into consideration of the frozen embryo transfer cycle, which now contribute quite a significant proportions of pregnancy after 1 cycle of ovarian stimulation. Then people try to add different sort of additional criteria. And you can see here, then more and more sort of people put the number of the embryos. So you may have 10 or 15, and now people may move even lower, say 6. I think it depends very much on the success of the implantation of embryos in your particular center when you actually come up with this sort of data. If you have very good implantation rate, certainly, then you can actually lower down the number of the embryos here. As I've said, the implantation process involves the interaction between the embryos and also the endometrium. So we try to actually look at the issues in these 2 aspects. Well, embryo, of course, as mentioned by Professor Paulson, aneuploidy is quite common, not only in aged women, but also in a lot of scenario, such as the repeated implantation failure. Well, if you look at the study available, then of course the number of subjects is quite small, but these are the data which suggested that women with repeated implantation failure may have a much higher percentage of aneuploidy rate when they compare with the control. But you can see here, their gain is very wide range. And they may actually have a high percentage which with complex abnormalities that involving more than or even 3 chromosomes. And this was actually independent of age. But when we actually look at these data, I think the great problem is the small sample size and also what sort of control groups that you're using. Whether you're talking about the fertile control group, which is quite difficult to recruit in many studies, or you're using infertile patients, and whether it's age match or not, that is important. Of course, the methodology used, whether you're using the fish techniques in the old days, which is not considered to be very optimal now, or whether you're using the array CGH. If we try to think along the line of the embryo, then there are 2 different ways that we can, in this sort of patients, to improve the success. One is using the selection. Then you can think blastocyst transfer or pre-implantation genetic screening. And you may actually improve the qualities by using assisted hatching, co-culture of endometrium or donor eggs, which I've mentioned in the literature. The blastocyst transfer, I think there are quite a number of studies using the blastocyst transfer in normal subjects. There's only one randomized trial that I can find evaluating the use of blastocyst transfer in patients who actually had repeated implantation failure. You can see here is a pretty small study, only 54 subjects. And they randomized into the blastocyst transfer and then also the day 2 early clear phase transfer group. So that you can see here, there's a significant difference in the implantation rate in the blastocyst transfer versus the early clear phase transfer. But there's no actual difference in the clinical pregnancy rate, probably because of the small sample size. And you can see here, the study was nearly published about 10 years ago. And there's another study which is prospective, but not randomized, a much larger sample size, 276 patients, which actually did not conceive after 2 early embryo transfer. So you can see here, different authors or investigators will use different criteria. And then you can see here the implantation rate is much higher, significantly higher in patients with blastocyst transfer, and also, again, you can't see any difference in the live birth rate, again, probably because of small sample size. But when we look at the blastocyst transfer, it may be just a selection. So it just echoes the finding that you may encounter in those normal patients. And whether it does help the patients in the cumulative pregnancy rate, that is another issue. Well, the pre-implantation genetic diagnosis is probably a very controversial area. I understand the foreign speakers will probably give more details on that. But this is actually the consensus statement published in Human Reproduction 2010. Because of the lack of the positive outcomes in 11 randomized controlled trial, then there's actually no evidence that the routine PGS is beneficial for patients with advanced age, repeated miscarriage, or implantation failure. There are some problems with all this study because there's a very high levels of mosaicism at cleavage stage biopsy, and also because all this study using the fish technique, then you won't be able to examine all the chromosomes inside the embryo. Well, this is the only randomized study that I can find, and this was published by the Brussels group. And you can see here 139 subjects with recurrent implantation failure, and then they randomized into 2 groups. One is pre-implantation genetic screening using the fish probes, and then for XY 13, 16, 18. So it's quite just a fraction of the complete chromosomes available. And you can see here, the clinical pregnancy rate actually is not different between the groups. Indeed, those patients in the control groups probably has a higher pregnancy rate. It just actually confirmed the other randomized trial done in other setting. However, if we look at the more recent papers using the comparative genomic hybridization method, which is said to be a more sensitive one, and you'll be able to completely evaluate all the chromosomes, then we may have different results. Of course, we are still waiting for the randomized control trial. It's not a big study, but it's 32 patients with repeated implantation failure. Then they will undergo polar bodies or trophectoderm biopsies. And using the comparative genomic hybridization, you can find the antibody rate was actually 65% in the oocyte and 45% even up to the stage of the blastocyst. Of course, there's no control group for comparison. And the implantation rate and the pregnancy rate after this polar body biopsies, then you can see here seems to be quite improved, especially in the blastocyst analysis, because the pregnancy rate can be up to 70%. But just to remind you, this is an observational study, and there's no actually any control group for comparison. So we're still actually waiting for RCTs in this area. Assisted hatching, this is the most recent meta-analysis published in Human Reproduction Updates in 2011. Okay, so there are 28 studies involving more than 5,000 participants. And there seems to be actually assisted hatching is associated with a trend of increased clinical pregnancy rate for all participants, but there's no actually improvement in the live birth rate. However, if we look at the different category, then in those patients who are actually unselected groups, especially you can see here, there's actually no significant difference in terms of the ongoing pregnancy rate and live birth rate, and also the advanced age or in the frozen embryo transfer cycle. But in the 3 randomized study in patients with recurrent repeated implantation failure, then you can see here the risk ratio was actually improved to 2.5. So there seems to be some role play in patients who have repeated implantation failure when assisted hatching was performed. Well, endometrial co-culture, there's only some observational study, and this certainly just a small number, and you can see here there's not really any recent papers on that. So if now we move to the uterine endometrial factors, there are a number of the uterine factor and endometrial factors which may again impair the implantation rate. So we try to quickly go through them. Well, hydrosalpingo is quite a well-known sort of adverse factor. It can be present in about 30% of women seeking help. And well, there's actually many randomized studies, and the 2 meta-analysis which shows the presence of hydrosalpingo is detrimental to the IVF outcome. And there are quite a number of hypotheses towards this reduction in the pregnancy rate. The hydrosalpingo, which causing mechanical barrier, and also there are also changes in the implantation markers which may affect the endometrial receptivities. Well, we have done actually 3-dimensional ultrasound to look at the endometrial blood flow, and we have shown that in patients who got actually hydrosalpingo, the endometrial and subendometrial vascularity may be actually reduced. And of course, it's compared with those without, so we postulate that may be a reason behind. Well, uterine fibroid is quite common in reproductive age of women. It can be up to 50 to 60%. And I think there's a lot of controversy surrounding the uterine fibroid. And I think now, based on the meta-analysis published more recently, I think it's probably quite clear this subserosal fibroid probably would not actually impair the IVF outcome. And on the other hand, the submucous fibroid will significantly reduce the pregnancy rate. However, the most common one, the intramural fibroid, I think is still controversial. Well, the meta-analysis published in Human Reduction Updates 2010, looking at 19 observational studies comprising about 6,000 IVF cycles, show a significant decrease in the pregnancy rate and also the live birth rate as shown here. However, there's actually an Italian study, Somaglian studies published in Human Reduction Update. They actually try to match the age of women, because very often when you look at this observational study, patients with fibroid usually are older, and they may actually have a slightly reduced ovarian response. The other thing that match is whether there's actually any sort of uterine abnormalities impinged by the uterine fibroid. So they will use a hysterosonogram to rule out any distortion in uterine cavities. And in this prospective study, they cannot actually find any changes in the IVF outcomes in terms of the pregnancy rate, ongoing pregnancy rate, and miscarriage rate. So this is still remain controversial. Adenomyosis is getting more attention. It's a benign invasion of myometrium. Although there's no definite relationship between the adenomyosis and infertilities, but there's concern about increase in the early miscarriage rate. I think this is quite an old study published, I think, in Taiwan. They've shown that those patients who have adenomyosis will have an increased risk of miscarriage. There's a more recent study, I think, from the Valencia group. This study actually got two parts. The first part is using their donor egg programs. So they actually have the donor eggs, which usually have coming from the very young donors. And then they look at the recipient to see whether they actually have adenomyosis or those without. And in their study, they cannot actually find any difference in the implantation rate and also the pregnancy rate, those with or without adenomyosis. So the egg qualities and embryo qualities are basically controlled, so they cannot find it. However, they see a significant increase in the miscarriage rate in those patients who have adenomyosis, 13%, compared with those with endometriosis or those without endometriosis and adenomyosis. So there's a significant increase in miscarriage. The second part is actually they are looking at those patients with adenomyosis to see whether there's endometrial gene expression between those with adenomyosis and without. And they don't find any significant difference or change in the peri-implantation gene expression. Well, intrauterine adhesion is quite common, I think, in some part of the world, because some women probably have repeated termination. And of course, the adhesion could prevent the implantation embryo. And if we do hysteroscopic divisions, and that associate with a high live birth in natural conception, and we cannot actually find a lot of information for IVF procedures. However, those patients with endometrial thickness less than 6 millimeters will probably have a lower pregnancy rate just because of endometrial atrophy. And the postulation is it may actually, in those patients who are actually subject to a much higher oxygen concentration during the implantation, which is not very good for the peri-implantation embryos. Well, the congenital uterine abnormalities, there's no clear relationship with infertilities, but in patients who have septate uterus, probably associate with a much higher pregnancy loss compared with normal control. Well, endometrial polyp is probably present in about 6 to 8% of patients undergoing treatment. And of course, now you can actually use the saline infusion sonogram to see it. And I think this is the only randomized study which is done in the IUI cycle, 200 sort of subfertile patients with endometrial polyp, then randomized into hysteroscopic polypectomy or just polyp biopsy. They wait for some time and then they can receive up to 4 IUI cycle. So those patients who have the polyp removed have a much better pregnancy outcomes compared with those without. However, if there's no actually any randomized studies in IVF cycle, there's some observational study saying that endometrial polyps may not actually affect the pregnancy rate if it's actually less than certain size. So it seems that the size may matter. But of course, again, there's no actually randomized study. There seems to be a trend of increasing miscarriage rate, but again, this is a very old study, very small number. Well, the endometrial blood flow is this is my research area. This is the small study involving 400 women with repeated implantation failure and then versus 8 normal control. They performed the 3D ultrasound, but they cannot actually find any significant difference between those with repeated implantation failure versus the control group. However, if they actually looking at the endometrial fluid, the uterine fluid, then they will actually have some changes in the cytokines compared with the normal control. So people, of course, try to look at the endometrial factors by looking at the implantation markers. These are just a few papers that they're actually looking at a particular sort of molecule. So reduced monoamine oxidase 8 or the MUC gene polymorphisms, and also the endometrial prostaglandin synthesis. These may have changes. And of course, this is only just a small portion of the molecular markers that involve. So another approach, of course, is to examine the gene expression in those patients with repeated implantation failure. Again, you can see here the endometrial biopsy was taken. This is actually not timed with average. That is one of the problems because you need actually to time it rather than just based on the cycle date. There may be changes in the genes expressions. There may be some genes actually get upregulated and then some genes get downregulated. So this will be actually provide you a global assessment of those implantation markers that involve. Well, natural killer cell, either you are measuring in the peripheral or in the endometrium. These are again very hot topics, and a lot of people will probably advise the patient undergo that sort of test. And this actually is a systematic review. They try to actually assess whether measuring the peripheral NK cell or uterine NK cell can predict the subsequent pregnancy and also whether there's actually increased risk of miscarriage. And a higher peripheral NK cell, we're talking about number or activities, actually do not predict any implantation failure or miscarriage in infertile women after the assisted reproduction. And of course, they try to look at those patients to see whether there's actually any changes in those recurrent miscarriage, but they cannot actually find any studies in this area. Well, because of the association of a number of the uterine factors with the repeat implantation failure, certainly the logical thing is to perform the hysteroscopy in this group of patients in order to confirm that whether there's any abnormality there, and if there, then you probably can treat it, and hopefully that can improve the pregnancy rate. So this is actually the meta-analysis published a few years ago. And this patient, it does actually reveal benefits if this patient actually undergo hysteroscopy. These are the randomized trial, which you can see here. The relative risk will probably increase. And even you look at the non-randomized trial, and indeed, if you look at those papers, they have actually found, even those patients without actually any organic cause, there seems to also involve improvement in the after the hysteroscopy. So then people ask whether this is really related to endometrial injury so that the patient actually have some improvement. So I think there are quite a number of you can see here, there are already 5 trials which actually addressing whether endometrial injury in this group of patients, whether it really improved their pregnancy rate. So you can see here, not actually very large number of subjects, is about 600. And 4 trials, the injury was actually performed in the luteal phase before the IVF cycle, the treatment cycle. There's only 1 trial which actually performed the endometrial injury on the day of egg retrieval. And there seems to be improvement in those studies which carry out endometrial biopsies or injury in the previous cycle. And you can see here the odds ratio is actually 2.5. So there's quite a significant improvement in terms of the live birth rate and also the clinical pregnancy rate. However, if there's actually injuries on the day of oocyte retrieval, then we can actually see a reduction. There's quite a significant reduction. So probably it's not really advisable to perform the endometrial biopsies in the same cycles. Well, as many speakers have mentioned about the individualization, now I think the concept is whether we are still actually putting back the embryo, actually whether you are talking about early cleavage day 2 or day 3 or day 5. Because I think the Valencia group, the Carlos Simon actually has shown in the data, in this group of patients repeated implantation failure, this may not be true, and they're using the endometrial microarray that they actually have done many studies. They will be able to characterize this group of women whether the gene expression is actually receptive or actually is pre-receptive or already post-receptive. So they will be able to try to actually, in those patients who actually are post-receptive, then whether they actually can change the day of the embryo transfer, then actually can improve the synchrony between the embryos and also the endometrium, so that they improve the pregnancy rate. Well, of course, this is a very recent paper they actually published in Fertility Sterilities, and they actually have some preliminary data which shows that in this group of patients, if you either advance the date or actually postpone the date of the embryo transfer, according to the endometrial receptivity array, they actually have shown very high success. And of course, we are now waiting for the randomized controlled trial that I think they are now undertaking to see whether that sort of hypothesis can be proven or not. But that certainly is a very important issue, is whether we should still stick with the same sort of day of transfer, or whether we actually need to look at whether the endometrial actually can tell us the dates that the embryo should be going to be put back. So I would like to conclude that, unfortunately, despite the very long sort of time of research, we are still waiting a uniform definition of repeated implantation failure. And I think high-quality studies are needed to develop a sound and evidence-based practice. And I think, of course, the understanding implantation process will be very important, crucial in identifying the effective treatments for repeated implantation failure. And of course, I think if you look at the evidence, I think that probably the improvement will be assisted hatching. I think the blastocyst probably there's one RCT, and pre-implantation genetic screening will probably don't have any RCT at all. And I think we probably can do the hysteroscopy to rule out any abnormalities in the uterus, and also we can do the endometrial injury or at the same time during the hysteroscopy. Thank you very much for your attention.